much for staying with us. You're watching Morning Cafe. My name is Anne Odide, and this morning, if you're just joining us, we mentioned earlier that it's World Ovarian Cancer Day, and that is the conversation you're having this morning, of course, with Dr. Afrin Fatima Shaffi, a gynecological oncologist. And of course, this is a day dedicated to raise awareness on one of the most deadly cancers prevalent to women. And Dr. Shaffi will just be telling us if it's the sixth or around the seventh rated cancer that is very, very deadly. And experts say 1 in every 78 women will get ovarian cancer. And sadly, in many cases, it's diagnosed in later stages. So karibu sana daktari to TV47. So good to have you.
Thank you so much, Anne. And I'm glad that we're here to celebrate the World Ovarian Cancer Day. Yeah. It is a very important day as we...
I was just coming to that. We're talking about World Ovarian Cancer Day.
Yes.
We usually have a World Cancer Day, but why is it important, for us to acknowledge that there is a day set aside to just celebrate and commemorate and to speak about these women who are brave enough, to live with ovarian cancer?
So basically, this is a day where we remember, we observe these women who have undergone who've had ovarian cancer, subsequently undergone the treatment. It's a very important day. It's a disease, or can I say it's a cancer that is very, very deadly, in that it's a very silent, can we call it, it's a silent killer. Because most of the women, and this cuts across the globe, present in advanced stages of the cancer. So not many women are able to pick up the symptoms because it has very, very subtle symptoms. And so the journey is very, very difficult. And in the reproductive tract cancers, this is one of the cancers that is extremely deadly because of its presentation. So yes, we see women battling with this cancer and how they overcome the disease, and there are those we lose as well. So we are celebrating, or we're observing their resilience, their strength, and of course creating awareness so that we can at least pick up or empower women to take charge of their health.
Mm-hmm. So this is a day we celebrate every year on the 8th of May. For all these years that we've celebrated these resilient women, as you put it, what are the strides that have been made? From the moment we commemorated the very first day that the world celebrated World Ovarian Day, up to now 2025. What are the strides? What are the gaps that still exist in terms of just equity, diagnosis, and just making ovarian cancer known to women worldwide?
Of course, over the years, people have come to know, or women have come to know, but we still have a long way to go in terms of creating more awareness, especially when we talk about equity. In terms of equity, when we look at cancer as a whole and we look at high-income countries and then we come to low-middle-income countries or low-income countries, there's a huge disparity in terms of cancer care and how people access care. But yes, since we started commemorating this day and remembering, we have created quite a substantial amount of awareness, and this will keep on going over. We will keep doing this over time and time. Every year that we remember this day, like currently Malaysia, Australia, they're all painting or in the essence of observing this day. They're painting their pictures teal in color to commemorate this day and to create awareness. There are women who are also having walks across the globe to highlight the symptoms of this cancer. So at least we are seeing more people coming to facilities because of this awareness. In terms, of course, over time now, we'll talk as we go along, we'll talk more about what has been made, what is new in ovarian cancer, and what changes in terms of treatment have been made over time.
Yeah, and this will sound like a very, very obvious question, but how does this ovarian cancer, given how the ovary looks like, how does it present itself? If you're looking at it from, I'll use an example of fibroids, we see how, the structure of the uterus is, how sometimes it's, small stones that show outside the uterus or something. But how does ovarian cancer present itself?
So basically, before we go into that, let me tell you what is an ovary. Okay. We want to know what is an ovary. So ovary is basically just this structure in the female reproductive, or it's a female reproductive organ, and it's a very, very important structure that produces eggs rather. And of course, it's responsible for producing the female reproductive hormones, that is the estrogen and progesterone. So this is very, very important. There are different parts of this ovary that from inside to the outside, the covering, the inner layer, and the innermost layer. So ovarian cancer can develop. They're now coming to this, the different types of ovarian cancers, and different types of ovarian cancers will occur in different parts of the ovary. So for when we talk about different parts, there's the covering, which we call as the epithelium. So these are cancers that we generally tend to see in older women. Of course, there's a theory, how does this occur? This occurs because there are certain risk factors, such as incessant ovulation. When I say incessant ovulation, what do I mean by this? So when women have a longer reproductive cycle, meaning they have many years when they're ovulating, so there's this theory that there's repeated inflammation or repeated trauma to the outer covering of the ovary, and this over time eventually can cause ovarian cancer. Of course, currently we have newer theories that are developing that say that the ovarian cancer does not really arise from the ovary itself, but can arise from the end of the fallopian tube, that is the tube that will carry the eggs. So there are some theories. Of course, all this is under research, but yes, these are the new upcoming theories that this ovarian cancer could be actually arising from the fallopian tube. And then there's about 10% of ovarian cancers that actually are hereditary. They're familial. They're because of certain mutations in the family, like the BRCA genes. This is BRCA genes. So women who have BRCA gene mutations in their genes are at a higher risk of developing ovarian cancers. Can be up to, 60 to 70%, depending on the type, BRCA1 or BRCA2 genes. Then there's another condition we call as mismatch repair gene deficiency. Even these women at a higher risk, up to say 34 to 35% risk. So yes, these risks are there. The general population, the lifetime risk of any woman developing ovarian cancer is approximately 1% or less. However, there are certain risk factors that increase the risk of a woman developing ovarian cancer. And like I said, 10% of ovarian cancers are actually hereditary. Yeah. Yes, and we have preventive strategies that can be used or that can be in place that can lead to the prevention of this development of this ovarian cancer.
When we say ovarian cancer is hereditary, is it that, say, a family where cancer is prevalent, is it that somebody from one family could have ovarian cancer, then somebody else is more predisposed to it, or any cancer, say somebody has breast cancer, lung cancer, blood cancer, it can translate maybe as ovarian cancer to somebody else, and not necessarily that somebody had ovarian cancer, so you will have ovarian cancer?
So breast ovarian cancer syndrome, that's when I say the BRCA mutation. So women with this, someone in the family can have breast cancer and they have mutations in the BRCA genes. Yeah. Now, the other person in the family can develop ovarian cancer because this is a syndrome. It's not only just breast cancer, it's a syndrome. So a syndrome of different cancers, like Lynch syndrome, women who have mutations in the mismatch repair genes, they are at a risk of not only ovarian cancer, they're also at a risk for development of colorectal CAs. So it's not, when we say hereditary, it's not only one. Yeah. It can be a spectrum or multiple cancers that places these women at a risk. So for BRCA, why I'm emphasizing this, because this is one of the most common hereditary conditions that can result or can lead to formation of ovarian cancer. So in which women this is prevalent is mainly the Eastern European Jews. However, that's why whenever we have women who have a family history of ovarian cancer, we advise them to undergo genetic counseling and eventually genetic testing, because if it runs in the family and the family members have the mutations in BRCA genes, then they can they will be at a higher risk of developing cancer, and subsequently they would need intervention, or can I say screening, annual screenings to rule out breast cancer, ovarian cancer. Yeah. So it's something that we generally would want to do, particularly in women who have these younger women who present to us. Yeah. In terms of again I said, in terms of challenges and disparity, there's a huge disparity when we come, like if you go to Europe or if you go to the North America, some of these tests are very easily accessible. However, when you come to our countries, when I say our countries, I mean sub-Saharan Africa or Eastern Africa for that matter, access to some of these tests is very difficult. We're not able to access these treatments. The cost of some of these tests is very exorbitant. Not everyone is able to afford the costs. So yes, like I said, there's a huge disparity, and of course we as a government and the necessary stakeholders need to take this into consideration and see how we can work together and make care accessible to everyone. Yes.
All right, I am made to understand that we should be Kasipule Ongondo Weri. But thank you so much for staying with us. We're talking about World Ovarian Cancer Day today with Dr. Afrin Fatima Shaffi, who is with me in studio this morning. She is a gynecological oncologist, and we've touched base on so many things, Dr. as at now. But you mentioned something about, ovarian cancer being a silent killer. So why is it so hard to detect it in such early stages? Because we started by saying 1 in 78 women will get ovarian cancer, but the diagnosis mostly happens in the later stages when the damage is already done. So why is it so hard to detect it at an early stage?
Okay, that's a very good question. Yes, why it's very hard to detect is because the symptoms are very vague. It doesn't have any specific symptoms. So women would experience, let me point out some pertinent symptoms that they would experience. However, they're general. So a lot of women would tend to ignore these symptoms. Yeah. And these include persistent abdominal bloating. I know a lot of us experience it. We say, it's just acidity, let me just ignore it. But no, if any persistent bloating, you're having persistent bloating for more than 3 weeks, please kindly get it investigated. Go to your healthcare provider. The other thing is anorexia, that is meaning inability to feed properly. You're not hungry, or early satiety, you get full very fast, There's loss of appetite, definitely, which is anorexia, I said, and then inability to feed properly. Urinary symptoms, such as you would go repeatedly to urinate or feel like urinating. So, and the other one is vague abdominal pains. That these pains can be in the upper abdomen or also lower abdomen. So these are very common symptoms, and you see that is why a lot of people or a lot of women would tend to ignore them. Yeah. Nobody would say, oh, you know what, I could possibly be suffering from a deadly disease, and we tend to ignore. We're so busy with our lives. So by the time we go to the doctor, the cancer is very advanced. And unfortunately, being very advanced, like I said, it is one of the deadliest cancers of the female reproductive tract, because the progression is really fast. In terms of treatment, it's not very easy to treat per se. And also in terms of outcome, the more advanced a cancer is, the poorer the outcome is. So hence, that's why we call it the silent killer. The failure to recognize the symptoms or go early to the healthcare providers. And like I said, it's not only in Kenya or Tanzania or Malawi. This cuts all across the globe. It's everywhere. Even if you go to the United States, you'll see the presentations are late.
So it's not always about, sometimes we women say when you're bloating is always the symptoms of PMS. So that is something that we should be taking keen interest in when maybe during the PMS somebody is bloating. Is that a sign that somebody should look out for?
So PMS, you see, it is related with the hormonal changes, and it doesn't persist. It occurs during a specific period of the menstrual cycle. However, when you have persistent bloating, and I say persistent, at least for a period of more than 3 weeks, then yes, it should raise a lot of questions in your head. And yes, it's always better to go to the healthcare providers, even if it's negative, you get a negative outcome, it's fine. at least if there is something, it will be detected.
Prevention is better than cure.
Prevention is definitely better than cure.
So when you have a patient referred to you, Dr. what do they come in for? What do they present as their symptoms? Is it pain, bloating, or maybe something just totally unrelated to what you've talked about?
Okay, so now this will have I'll answer this in two bits.
Okay.
When you go to when you're in a public sector, a lot of women, like the kind of patients you would see in the public sector are patients who are from the lower socioeconomic strata. Okay. So most of these patients don't have access to treatment. And I emphasize this because I see this on a daily basis. So when they come to the public sector, you'll see the presentation would be slightly different because somebody would come with an abdomen that is this big. She's had this mass for like months, but because she did not have access to that care, or she was not able to go to that facility, or she didn't have money, so she was not able to come. So she would come with very advanced disease or very huge tumor, a very huge tumor. So this is some of the
abdomen.
Yes, someone would come like with something which is 10 kilos, and you ask, why would you come so late? But again, like I said, there are loads of challenges when it comes to oncology care in Kenya. And not only in Kenya, also in other East African and Sub-Saharan countries, So when you go to the private sector, yes, like I said, even those women would come with, would also come with advanced symptoms, but maybe someone is more aware, is more health conscious, and perhaps a person is going more frequently to the health facilities. So maybe you wouldn't see those advanced cancers, that much of an advanced cancer in the private sector. But however, like I said, most of the women would present with an ovarian mass or with abdominal swellings. This would be the commonest presentation that would see. Incidentally, yes, we do pick up some when they've come for some other thing and they've undergone a scan and then or some abnormal bleeding and they've undergone some tests and then they would be referred to us. So yes, these are some of the presentations that we would see. But like I said, most of our patients with ovarian cancer usually tend to come in with advanced diseases.
Something like cervical cancer, for instance, we hear about the pap smear.
Yeah.
But what about, that helps, of course, to detect the presence of, the cancer in the cervix. What about the ovarian cancer? How do you as, doctors now do it to try and just see that this could be ovarian cancer?
Okay, so unfortunately, and I emphasize this, unfortunately, we don't have a screening test for women who are at an average risk to screen for ovarian cancer. There is no screening test for ovarian cancer. And a pap smear does not diagnose ovarian cancer. It is for cervical cancer, and sometimes you may pick other cancers like an ovarian cancer, but not really, mainly for cervical cancer. Now, coming back to ovarian cancer, with ovarian cancer, yes, we don't have a screening test for average women. There have been several studies that have been done. Yes, people would say you can go for an annual ultrasound or CA-125. These are specific tumor markers, but in terms of them being useful in a woman who's at an average risk of developing ovarian cancer is really not beneficial. In fact, it can rather cause harm in that they may warrant additional invasive testing. So in a woman who's at an average risk of developing ovarian cancer, unfortunately, we don't have any risk of any screening test that would that would be beneficial. However, women who are at a higher risk of developing ovarian cancer, and when I say higher risk or high risk of developing, these are women who have mutations in the BRCA genes that we talked about, women with a family history of ovarian cancer. Now, this puts the women at a substantially higher risk of ovarian cancer. So for these women, yes, we do recommend screening, and for both the breast and the ovaries. And in terms of screening, we would recommend them to undergo transvaginal ultrasounds, basically, at least annually or between 6 to 12 months.
What is that?
It's an
The transvaginal
ultrasound.
Ultrasound.
So basically, it's just an ultrasound, the normal ultrasound that we do.
Yeah.
So now, transvaginal ultrasound, we don't do it through the abdomen, we do it vaginally. We insert a probe because that will delineate the organs better, and you're able to characterize or see the ovaries better. So that's why we prefer to get a transvaginal and not an abdomen or pelvic ultrasound. Along with that, we combine it with a tumor marker known as CA-125. So this is recommended for women who are at a high risk, like women with BRCA mutations or women with a history of Lynch syndrome. So yes, for these women, we would recommend. But for the average woman, no, unfortunately, they're not. The only thing you need to watch out for is the symptoms. Yeah.
So that means that somebody can be suffering, say, get even to the later stages of death, you know, let's just say the way it is, for them now to get the help that they need. But you're saying that this particular disease, it doesn't have a treatment, for instance. It can be managed, rather. So somebody just waits until it gets worse?
Okay, so once the women present to us and we do diagnose or we pick up what we think is ovarian cancer. So of course, when it comes to treatment, the treatment is basically divided in two phases. There's some women would require surgery alone, some would require a combination of surgical treatment plus medical treatment. And when I say this will depend, the treatment basically depends on the stage of the cancer. So if a woman has an early stage cancer, meaning when the cancer is just confined to the ovary, it hasn't spread outside the ovary, then this woman, and of course we also look at other types of risk factors after surgery that may warrant additional treatment. So these women will need to can have upfront surgical treatment. Again, the surgical treatment will depend on the kind of cancer we're suspecting, the age of the woman, and so we'll tailor the treatment. Basically, the treatment is tailored on a number of things. And women who have advanced cancers, we may not be able to operate upfront. Yeah. So sometimes what we do is we would give chemotherapy to downstage the cancer because it may be very difficult for us to remove the cancer in the first sitting because it's spread to most of the parts of the abdominal cavity. So you may not be able to remove it. So what you can do is in these women, you may give some chemo, reassess their response to chemotherapy. And if you think after a certain number of chemotherapy cycles, these women are doing well, and yes, the cancer can be removed, then we go ahead and operate on these women. And then, of course, there's the chemotherapy part. So the treatment is quite a long treatment. And yes, in terms of relapse, again, meaning treatment failure or recurrence of the disease, most of the ovarian cancers, particularly the epithelial ovarian cancers, tend to recur within 2 to 3 years, around 80%. It will also depend on the stage, like I said, and the response to treatment. But yes, they do recur. We have other maintenance therapies that we would put. Currently, yes, we use the terminology, the chronic cancer, you know. Sometimes you can prolong the life of the patient by putting patients on specific drugs or maintenance therapies. They may increase some survival, or can I say prolong the life of the patient.
Yeah. You know, let's go back to the BRCA one that you were talking about. What are the preventive strategies that exist for ovarian cancer? Say, before somebody actually presents the symptoms of ovarian cancer, say the bloating, the pain, the abdominal pain, what can be done really before that? Okay,
so for BRCA, women who have BRCA mutations, one of the main preventive strategies that we do recommend as GYN oncologists is a risk-reducing salpingo-oophorectomy. Now, I know that's a huge word, risk-reducing salpingo. Yes. Okay, so what I mean by that is we would recommend removal of the ovaries and the fallopian tubes in these women. That would decrease the risk of developing ovarian cancer by 80%, which is a substantial reduction. And of course, the recommendation, when we talk about recommendation, we would want these women to get the surgery done before the age of at the age of 35. which I know there's a lot of, when we talk about removing your ovaries or your uterus, there's a lot of stigma and cultural issues that would surround this. So it's not something that is it's easier said than done. But yes, this is one of the preventive strategies, and there's a substantial reduction of ovarian cancer in these women. So we can also offer it to the women after they've completed their family. But yes, there's a specific age group that we would want them to get it done, because these women, again, that are at a higher risk of developing cancer earlier than the other women who would develop epithelial ovarian cancers.
If you remove these organs as a way of preventive strategies of this cancer, is it guaranteed that this patient will not have ovarian cancer in the future?
So, like I said,
because we were talking about relapse, a relapse occurs after 2 to 3 years.
Yep.
Of course, this is after treatment, chemotherapy, and all the treatment available for ovarian cancer. But say we are preventing it, you remove the ovaries, you remove the fallopian tubes. Is it guaranteed?
Okay, in terms of guarantees, nothing is guaranteed. Like I said, it reduces the risk by 80%. So there's also that 20% that the woman may still develop. But you see, the organs where the ovarian cancer develops is the ovaries. So we have removed the structure. But so we reduce the risk of these women developing cancer substantially in the organs. The organs that are supposed to develop cancer is already removed.
So how is life after treatment? You see, these patients has lost the fallopian tube, the ovaries. How is their life after treatment from now a doctor's perspective? Okay,
so yes, it's life after treatment is quite, it entails a lot of things. And this is the most important part that we as doctors or healthcare providers sometimes, or even patients themselves, would neglect, But it entails a number of things, which include lifestyle modifications. And in terms of dietary, we would want patients, what we call is a cancer survivor. After treatment, we would want these patients to basically live a healthy life. And this is perhaps switch to more plant-based diet, cut down any excessive red meats, sugars, and then incorporate regular exercise, at least 150 minutes of moderate intensity aerobics exercise with, resist strength training at least 2 sessions a week. Additionally, you see, the treatment, of ovarian cancer is very radical.
Yeah.
We're removing a female's reproductive organs. So this plays a huge role on the body image, on the sexual health. So there's so much around this. The women constantly would need counseling. Of course, it's always important and, helpful when someone would want to talk to another person who's undergone the same journey, And so there are groups where women can join, counseling groups, or just have counseling sessions as well. Additionally, of course, follow-up care. Now, we talk about follow-up care. Women, once we have completed our treatment, it doesn't finish there. These women need to be on a long-term follow-up. They would need to come in to get regularly tested and see how they're doing, how the disease is, if the disease has recurred, Additionally, of course, we also talk about preventive strategies and vaccinations in these. They need to keep up with the vaccinations, with the chemotherapies or certain immunotherapies. A woman's body, the immunity decreases. So yes, they need to get their flu jabs, and other vaccinations which are recommended. Yeah. So yes, these are some of the components, of follow-up care or survivorship, or treatment life after treatment, that we need to educate the women about.
You see, we have other conditions that are always around the ovary area there. We have fibroids, PCOS. Now we hear about endometriosis. Are these conditions sometimes mistaken for ovarian cancer?
Okay, so the ovarian cancer diagnosis is a histological diagnosis, meaning sometimes we need a tissue diagnosis. So in early stages, sometimes, yes, they may be mistaken because we don't have a tissue sample, but there are specific features that suggest to an invasive or to a cancer as compared to the benign features. So for fibroids, basically, most of the fibroids, can I say, they are inside the middle layer of the uterus. So they're not in the ovaries as such. So that would differentiate. They're quite, as a clinician, I would say they're differentiating features that would differentiate an ovarian cancer and fibroid or endometriosis. However, endometriosis is a risk factor for ovarian cancer. Women who suffer from endometriosis can develop ovarian cancer at a higher risk of development of ovarian cancer.
That's quite sad. You know, we have a lot of cases now, women coming out to just say how they are suffering from endometriosis.
Yeah.
There isn't a cure for that, is it?
Okay, so for endometriosis, we have experts in our country.
Yeah. All right.
I'm not the best person to talk, but yes, it's mainly a symptomatic management, and yes, which entails part of surgical management, and they would be the best people to answer that question.
Right. Yeah. Are we seeing a surge in, the cases of ovarian cancer in the country or in the world, from where you sit? Or, are we opening up our minds to just talk about it now? And it's something that has been there, but it wasn't something that was talked much about. So are the cases increasing now, or the numbers are gradually decreasing? Okay,
so that's a good question. I think we should have talked about it right in the starting. Yes, so we're seeing more cases of ovarian cancer. Currently, if we look at the statistics in Kenya, we have the incidence rate of ovarian cancer is 1,250 annually. That was as the current data as per the newer statistics of 2022. Worldwide, we have approximately over 300 cases that have been diagnosed. But yes, I would still say that most of these cases are underreported, and we have many more cases rather than those which are reported, because these are of women who have actually come to the facilities and have been assisted, and they have every country or has cancer registries. So these are cases that are already registered. But like I said, there are many, many women who don't even come to the facilities or would go to a district hospital where they would go undiagnosed. So yes, by the year 2040, the numbers are predicted to become double of what they are currently. So yes, we need to create more awareness and more in terms of advocacy and presentation of these women to healthcare facilities.
This year's theme is No Woman Left Behind. Do you really think that a lot of women in Kenya are more informed about ovarian cancer? And does this year's theme, the No Woman Left Behind, really align with what you're trying to achieve in terms of just management of ovarian cancer and treatment?
So when we say no woman, this is what our manifesto is, or what we want to achieve at the end of the day. Yeah. But yes, we know it's not possible at the moment, because yes, we have penetration. We would say we have mobile penetration, or everyone in the village has a radio. But again, how many women are able to listen to that information, or how many women can recognize? Yes, when we're in Nairobi or say Mombasa or Kisumu, we know it's easier to disperse information. Yeah, and it's easier for those women to be more health aware of their health and come to the facilities. But when you go, say, to the interior parts of Kwale, or you go to Isiolo or these places, women are not aware. It's difficult. So yes, that is why we need to take initiatives that are going to educate these women more. And so women are able to come. Again, there's that aspect of women empowerment. Our women are not empowerment. And yes, it saddens me quite a lot to say this, but we have a predominantly very patriarchal society. Yeah. So a lot of women would need financial support or some sort of support from the male members of the family to go to the health facilities. And I'll give you an example of this. So I had a young woman who came to me, and when she was diagnosed with with ovarian cancer, her husband just abandoned her. And all financial support was stopped. She literally had no support, So for a good almost 8 months, she was aware. So when she came back now, she came with very advanced cancer. She literally had no financial support, and she was not able to come to the health. This is the story of one woman, but I'm telling you, this is the common scenario with every other woman in Kenya currently. Yeah. it's unfortunately a very sad scenario, but this is the reality.
But for cases like the woman and other women living in impoverished conditions, what is available for them in terms of treatment? Is there like a waiver, or what do you do as doctors just to try and also make them feel seen and heard? In line with this year's theme, no woman left behind.
So, yes, our government has made, can I say, the NHIF, or now the SHA, does help a lot actually in terms of treatment. And we see these when the women come in and they have no support. The SHA stands a long way in helping in terms of treatment. Most of the treatment, can I say about 60, at that time around 70% of the treatment. Of course, the hospitals also offer waivers, but again, you see, in terms of a lot of drugs, we can waive for 1 patient, 2 patients, but then there's so many out there. And the drugs need to be procured, the medicines need to be procured, so it has to be an initiative from the government, from the main stakeholders, that will provide some sort of solution to all women where they can access care and not really rely on, can I say, on the with the waivers, with the NHIFs. But you see, you can't keep waiving. I'll just be very realistic. It's not very realistic to waive for 100 women. Unless government is supplying free drugs or free chemotherapy to the facilities. If they do that, then yes, it's possible, but otherwise it's unrealistic to say that you're going to waive for 100 women, you know. No, I'm just trying to put the whole scenario as it is, so it gets difficult.
So what are the new strides that have been made in terms of managing ovarian cancer?
So in terms of managing ovarian cancer, we do have newer drugs that are coming in, like the PARP inhibitors or other immunotherapies like bevacizumab. And yes, these have shown promising results. However, again, I'll talk about the financial aspects of oncology or cancer care in Kenya. It can be quite draining. Most of these drugs just require a long-term usage, you know. So perhaps one course, or can I say a month's course, might cost you 150 to 200,000. So yes, we do have these drugs in Kenya. Yes, they are available, but in terms of cost, they are quite costly. They are quite costly, unfortunately.
Sadly, not everyone can afford it, and
Yes.
it cuts across. You know, that amount. If it's 100,000, even the one in the poorest of conditions pays 100,000 for it.
Yes, but yes, like I said, SHA would pay part of it, but not all of it.
Yeah.
So you see, after a certain time, maybe 2 courses or 3 courses, your finances are drained. So again, you start now what?
But you know, we don't talk much about it. You know, how ovarian cancer also, the fertility risk that it poses to women, especially those who want families but haven't, you know, started the journey towards, say, giving birth, doing 1 to 3 with their bodies. So how does this now affect the quality of life of this woman who wants a child? Yes.
Okay, so now again, that's quite a good question. We do offer fertility sparing surgeries to women who can be offered. Like I said, there are specific histological types and specific age group and the stage of cancer where we can offer certain treatments that are more conservative rather than very radical treatment. Of course, there's the other thing of cryopreservation where you can preserve your eggs as well. So these are some of the options for fertility preserving in younger women who desire to conceive.
Yeah. There's a question here for you that I was looking at as we continued. She's called Ruth Sherry. She's asking, when it comes to awareness, we always say know the signs, but is that enough, Daktari? Or should we be talking about screening just the way we talk about breast or cervical cancer?
So again, coming back to screening, yes, the most important when it comes to ovarian cancer is know the signs. Because there's really no screening test that we have and that has proven to be effective in prevention of ovarian cancer. So unfortunately, at the moment, we don't have a screening test for women at average risk of developing ovarian cancer. But yes, it's important that we know the signs and we don't ignore our body.
There's another question. Ovarian cancer doesn't get as much attention as breast or cervical. Do you think there's a reason why it gets sidelined?
Okay, that's because when we look at breast cancer, yes, in Kenya currently it's the 9th, can I say, yes, one of the top 10, but it comes at 9th, where the incidence rate is around 1,250 as compared to cervical cancer, which is, can I say, we lose 9 women every day to cervical cancer. The rates are quite substantial, almost more than double of what we have ovarian cancer. That is why, and in terms of prevention, we have preventive strategies for cervical cancer. But having said that, I think it's a disease that should not be ignored as well and should deserve equal, can I say, advocacy, and we need to create more awareness about it as well.
And just a follow-up on that question, you know, she's asking about this not being given much attention as it should. So from where you sit, what do you think would take to bring the conversations about ovarian cancer to, you know, the front of health conversations, and maybe policymakers to just try and do something for women who cannot afford treatment, to create more awareness about ovarian cancer to, you know, rural areas in the country, just across board?
Yes, I do believe that as policymakers and as stakeholders, we need to stakeholders and policymakers need to create more awareness, and in terms of also provision of care, we need to advocate for subsidized treatment costs for this cancer, because like I said, oncology is a very expensive affair, can I say, in our countries, and yes, the access to treatment. Again, one of the things that I'd like to point out is access to the treatment. You know, not recently we did a study where Kenya was one of the countries which participated in a multi-center study which was done in 24 countries, and we noted that 80% of our women are not able to access these facilities because somebody would stay 150 or 200 kilometers away from a facility that is offering treatment, and we have a centralized facility. So you see, even them getting to those facilities would take months before they can get. So yes, stakeholders and policymakers need to take that into consideration and to mitigate some of these measures or develop some sort of referral pathways where these patients who are picked up need to be referred to these facilities as soon as possible. So there's a lot to be done, and that can be done.
Shaletta Tiena is asking, when it comes to health checkups, how often do you recommend we should go for reviews?
So at least for a general health checkup, at least annually, we should get a health checkup done. Yes.
I want to take you back to a comment you made about the lady who was left by the family, by the husband rather, when they presented that, you know, they suffered ovarian cancer. But are our men also involved in this? If you're talking about creating more awareness about ovarian cancer, we're talking about women, the theme, no woman left behind. But don't you think that men should also be brought to the table to be taught about ovarian cancer? Because when we talk about mental health, for instance, GBV, we usually say that men are allies in ending gender-based violence. But can they be allies as well in just supporting these women who, you know, suffer from ovarian cancer?
Absolutely. Men need to be integrated. Partner integration is very, very important. And when I say this is because the various, as not only from the time that they are aware, you see, they can encourage the women, not only the partners, we also need to integrate communities in that, because communities play a very vital role. And most of the communities are headed by the male members. So yes, it's very important that we integrate, because even post-treatment, like I said early on, that when women undergo the surgical treatment, it's a very radical surgical treatment. So even the men need to understand that aspect, and they need to be equally supportive. Yes, we see a few men coming with their spouses or their partners to the clinics, but we need more of the men, more of the male partners coming to these clinics and come for the treatments, you know. This will encourage more, can I say, regular follow-ups and more support, you know. But yes, again, I'll refer to that study which was done in Western Kenya. Again, we saw that a lot of women are abandoned by their partners once they get a diagnosis of any reproductive tract cancers. You know, there's a lot of stigma that surrounds reproductive tract cancers, but particularly it comes to, they would say it's, you know, there's a lot of myths saying that it's related to promiscuity or XYZ, you know. And so this is something we need to break. These are the barriers that we need to break and overcome. Yes.
So would you say that our doctors in the country and gynecologists are well trained to just notice or see ovarian cancer early, or are there still gaps in the medical sector from where you sit, your colleagues?
So I would say, yes, my colleagues are quite well trained and to pick up these cancers and to refer, like the general gynecologist, definitely a lot of them would refer to the gyne-oncologists. And yes, they are, the training is the same. We have good training institutes in Kenya, say University of Nairobi and MTRH. They all have oncology centers where a general gynecologist would pass, or can I say would go through the cancer department. So yes, in terms of training, we do our best. And yes, our colleagues are quite collaborative in terms of referrals and consultations, but yes, we can do more. We can do much more.
Now, from the rural areas, for instance, do we have, you know, enough gynecological oncologists, I hope I say that right, to just help in seeing the symptoms early for referral purposes? Or is there still a gap in the rural areas, for instance, in terms of just medical access and, of course, diagnosis and giving medication to these women who present with symptoms of ovarian cancer?
Okay, that's a good question again. So why I would say that is currently our population is 56 million, approximately 56 million. In Kenya, with the 56 million population, we have about 20 to 30 gyne-oncologists serving this whole population. So, you know, that is just a very small fraction. So no, we don't have enough gyne-oncologists. We need more gyne-oncologists. We need to train more people. But again, there's some other aspects that, yes, we wouldn't have a gyne-oncologist maybe in the extreme interior, but we'll maybe have a gynecologist. So yes, that is the thing now, like I said, to work hand in hand and collaboratively with our colleagues. Not only the gynecologists, but also the medical officers, the nursing team, you know, medical fraternity, we all need to work together. So when we work together, it prevents and, can I say, it would smoothen things. So when a person sees that looks something like ovarian cancer, then we can do the referral. So education, you know, in most of the smaller facilities, you'd see a lot of clinical officers. Now, our job would be to sensitize them on ovarian cancer, to recognize the symptoms and how to refer these patients to the appropriate specialties. That is what we need to do. So that is mainly strengthening the pathways, referral pathways, and educating the rest of the, can I say, the clinical officers, the nursing officers, yes.
So what are we doing today to celebrate World Ovarian Cancer Day? You mentioned Malaysia, they have a walk, they're paying.
Yes, I think.
Still, in Kenya, what are we doing today?
In Kenya, I think several of my colleagues are having some talks in some institutions. Yeah.
Trying to create awareness in that.
We're just trying to create awareness, yes.
So from the conversation as we wind up, of course, that we've had this morning, if there's something that a woman is watching right now, you would want them to pick from this conversation on ovarian cancer, what would it be?
I would like all women to take charge of their health, and my message to all women would be recognize the symptoms. And the symptoms are persistent bloating. If you have any bloating more than 3 weeks, please see your healthcare provider. Frequent urination, any abdominal swellings, don't sit at home. Please seek medical help.
Absolutely. That is Dr. Afrin Fatima Shaffi, a gynecological oncologist, talking to us about ovarian cancer. Today is the 8th of May, World Ovarian Cancer Day. And remember, 1 in 78 women get ovarian cancer, and in many years it gets, you know, gets diagnosed later on. And this is one of the most deadliest cancers on women. That brings us to the end of this conversation, but don't go too far. Gym fitness is coming up next. Stay with us. You're watching Morning Cafe. Good morning.